Well, welcome to everybody to this meeting. We know that in our daily clinical practice that the control of our allergic rhinitis patients is usually suboptimal, at least for a big part of it. But we will try to analyze today, during these 20 minutes, what is the reason of that and the tools that we may use now or in the future to deal with these patients. We already know that the prevalence of allergic rhinitis in Europe is very high. It goes from 15 to 30%, depending on the countries. This is the data that we have for the general population, although there are several data in different parts of the world. And this prevalence is increasing from child to adolescent to adult. You can see in this slide that there is a number of regions in the world that they have the same behavior. Usually they have about 5–8% of allergic rhinitis in childhood, that grows to 15, 16, 17% in adolescent people, and then reach 20, 25, 30% in adulthood. We may also differentiate patients depending on the duration of symptoms, on intermittent or persistent. And also we are able to differentiate in 2 or 3 levels. More recently we have this data of severity, mainly based on the impact of these symptoms on quality of life using the ARIA, the 4 ARIA items that are sleep, impairment of daily activities, abnormal work on school, and troublesome symptoms. Recently, these 4 items or these classifications have been also validated using in a Spanish cohort with a high correlation between the VAS score of severity with these 3 levels of severity. One of the main objectives of the last 15–20 years has been to treat patients globally, and one of the main comorbidities of allergic rhinitis is asthma. It's not the only one, but probably it's the most important. And we all know that there is an increasing risk of having asthma or developing asthma or even developing severe asthma if we have rhinitis, or mainly if we have allergic rhinitis. And this development or this leading to asthma will be higher in severity if we don't treat correctly or properly allergic rhinitis. But there are several factors that control this severity or the control of patients. And I think this slide summarized a global concept of all these factors. Some of them are disease-related factors, for example, this global respiratory disease. Diagnosis-related factors. The main of this is the incorrect diagnosis. Sometimes we can diagnose an allergic rhinitis when the problem is not this rhinitis, and maybe it's chronic rhinosinusitis or other problems like septal deviation or hypertrophy of turbinate, so on. Treatment-related factors, also linked to this misdiagnosis. We will see some data on that. And patient-related factor, what is very important, and the main factor associated to this bad response or this uncontrolled is the poor adherence of patients to treatment. That is probably one of the main objectives of doctors today have in their daily practice. For example, about the adherence to intranasal steroids in rhinitis, there is this recent study performed in Turkish populations where they identify some of these factors. For example, are more adherent parents that have less than 2 children, in this case. Those patients that better benefit of drug, of course. If a patient don't benefit, they don't feel any benefit from a drug, they will discontinue the treatment. And also the education. The patient who is educated at university level or postgraduate also are in general more adherent to treatment. In a recent study, not yet published due to, through the ARIA APP, it has been found that in a treatment of 15 days of intranasal steroids for allergic rhinitis, only 6% of those patients really do the treatment. And this is very, very low. It's less than 1 in 10 patients. But also misdiagnosis is important. We all know this data that about 86% of patients with asthma have nasal symptoms, and this is usually attributed to allergic rhinitis or to rhinitis. But when you carefully look at what happens, or if using ARIA guidelines, EPOS guidelines, and GINA guidelines behind these numbers, we found that 50% of those patients are really rhinitis, some non-allergic, some allergic, and 35%, one-third of them, are really chronic rhinosinusitis, with or without nasal polyps. If you treat those patients as regular allergic rhinitis patients, probably you are not going to be successful on the treatment. And that is an important issue to control. In the ARIA guidelines published in 2008, there was already an algorithm to try to distinguish, using only symptoms, between allergic rhinitis and chronic rhinosinusitis, and that it's not going to solve all our cases, but probably it will really discriminate a number of patients, differentiating between allergic and non-allergic and chronic rhinosinusitis patients. Smell is another one that this is one of the fields that I feel more comfortable because we have produced a lot of data on that. We have linked the loss of smell in allergic rhinitis in adults to the more severe group of patients. The patients with allergic rhinitis, that's 33% that have loss of smell, usually are linked to the most severe disease. And this not only happen in adults, this also happen in children. And there is an increased loss of smell going from mild to severe patients, either in frequency or in intensity of loss of smell. This figure published by Peter Hillens and recently shows that uncontrolled rhinitis can also come by a mixed rhinitis that could be infectious, allergic, non-allergic, that can be presented in the same patients, but also by the presence of other abnormalities in turbinates, in the nasopharynx, in septum, in the nasal valve, that should be taken into account, mainly in children. And we have conducted one study that the first part was published last year, and there is a recent paper on the sense of smell and the role of control of these patients in the JACI in practice of this month, where there is a link between treatment refractoriness in allergic rhinitis with obstructive turbinate enlargement and septal deviation in children. And if you see to this graph, you will see that looking at the sense of smell, there is a strong correlation or a strong association of loss of smell in patients with treatment refractoriness, severe rhinitis, and obstructive turbinate enlargement, while normosmia, the normal sense of smell, is very much related or associated with well-controlled allergic rhinitis in children. We also know that allergic rhinitis that we deal as specialists or GPs, usually we see a number of moderate and severe. Why? Because usually mild patients don't go to see the doctors. They are treated by pharmacies or they are self-managed. And several studies show that about 70% of the patients that we see in our clinical practice are severe. Most of them show mixed forms of allergic rhinitis. Many of those patients are polysensitized, and about one-third of them belong to the group of what we call it the SCUAD, the severe chronic upper airway diseases. These are the most severe, and these are the more difficult to control in our clinical practice. In this study done in Finland, they found that there is a strong severity in those patients that have persistent allergic rhinitis, that in those that have intermittent, increasing the cost of the disease to almost 3 billion euros in Finland per year. That is not much, because you will see recent data that we have in Spain that is much more than this. For example, there are many studies that have shown that up to 90% of the patients take 2 or more medications to treat their allergic rhinitis. 60% of them are very interested in finding new medications because probably they don't achieve the control of the disease. And 1/4, 25%, are constantly trying new medications to treat their disease because they don't have, they don't feel the improvement or the total control of the disease, of their disease. For example, in this French study published by Jean Busquet, they showed that most of the patients were currently taking medications, about 73%, but most of them remained with symptoms. From 70 to 90% of them, they have different symptoms, and the level of severity presented here by the VAS score was about 6, no matter if they were treated or they were not treated. I mean, that is very important. That means we are not able to control these patients because we feel that we have at least a partial control when we are below 5 or below 50 millimeters in this scale. In this UK study, they found similar findings. I mean, 71% of the patients that they were analyzing were treated with 2 or more medications. And the reason these patients gave to use more than one medication was in 70% of the cases because they were looking for more efficacy, and 24% faster response. I mean, most of the patients were increasing the number of medications because they were looking to more and faster effective treatment that they couldn't find. But although they used this number of treatments to control the disease, almost all of them, 70% were using this increased number of drugs, but without much relief or much change or control on the disease. In Spain, we have data that independently of the duration of the disease, you can see here data on intermittent or persistent, 2/3 of our doctors give 2 or more drugs to our patients, mainly intranasal corticosteroids and oral steroids. And this is not clearly stated in international guidelines, nor demonstrated for studies. And even worse, no matter the severity of allergic rhinitis, mild, moderate, or severe, 2/3 of doctors give these 2 drugs or more to our patients. Of course, this increases a lot the expenses or the cost of the disease. We have recent data also that no matter how we treat our patients, for example, in the severe group, that is this one, you are able to control only 50%. And if you consider all of them, moderate, severe, you are able to control only 56% of the groups, remaining 44 uncontrolled in a general cohort of allergic rhinitis. And these are the recent studies showing the cost of the disease of allergic rhinitis in Spain. You see the average is about 2,000 euros per patient and year. That is increasing, of course, from mild 1,600 to moderate 2,200 and close to 3,000 euros per year. The general cost of allergic rhinitis in Spain, we have about 45 million population, is about 20 billion euros per year. And this is an enormous amount of money to use for a disease like allergic rhinitis. Which methods we may use to assess severity and control? Usually when patients are not treated, a good classification is use allergic rhinitis severity, as is done in asthma. But when you already are treated or are treating those patients, what you want to know is if this treatment achieves control or is able to reach control. Because severity can change it, while control gives you an approach to the assessment of the treatment objectives. And assessing of control combines severity, quality of life, nasal function, or exacerbations, as is done in asthma. There are, of course, other definitions that are not excellent. One of them is responsive to treatment. And you can classify patients no matter if you are classifying by severity, by control, or by responsiveness to treatment. How we can measure this control? There are several questionnaires that have been validated, some in the United States, some in Europe. We have 3 of them here. For example, the CARAT, the Control Allergic and Asthma Test, with 10 items. The Rhinitis Control Assessment Test, the ARCAT, with 6 items, and the ARCT, the Allergic Rhinitis Control Test, with 6 items. That is mainly used also in France, while ARCAT is used in Spain and many other countries. But recently, ARIA has validated and adopted an easier way to control the disease, that is using a VAS score, using 3 levels, or 3 cuts, mainly 2 centimeters, 5 centimeters, from a line of 10 centimeters, dividing the patients in well-controlled, in poorly controlled, or uncontrolled. And we have some data of this. This is so easy that even can be used in the allergy diary applications that can be downloaded from many countries of different languages, 16 languages, I think, 17. Or 17 languages. And it's so easy that using a finger to move the bar and control to have, for the patients, a better control that can be also analyzed and stored and seen in the visits from the physicians. In a recent study called CORINA, done in Spain, we have found that there is a clear correlation between this VAS score using the APP and the questionnaire of control that we have validated for the disease. That means that we can use either one, and both are useful to assess control, but probably VAS score is much faster and easier to use it. What is the impact of treatment? We have many treatments. The recent data that we have from the evaluation and the grade from ARIA, we have first-line drugs that are very potent, intranasal corticosteroids, antihistamines, either oral or intranasal, the intranasal formulation of MPS-flu, and oral corticosteroid in some severe cases. There are then second-line drugs like intranasal hormones, intranasal decongestants, oral decongestants, or intranasal ipratropium. And then we have other drugs that are able to treat both the nose and the bronchi, but they usually are used in the patients that don't respond to the regular treatment, or in addition to. Antileukotrienes, subcutaneous or sublingual anti-allergen immunotherapy. This afternoon we will have a whole session dedicated to that, and omalizumab, biologicals that also have been used for that. There is very recent data that MPS-flu has a better impact on the symptoms and improvement in quality of life from the very beginning, from the very first day of treatment, compared to the corticosteroid alone, and it's considered the first line of treatment for moderate to severe patients. There are many other formulations that are being investigated, not only fluticasone with acetylcysteine, but none of them are yet commercially available for the use in clinical practice. For example, this drug has been used to investigate the role on the control of patients. And you can see here when you have patients with less severity or more severity, that in both cases you are able to decrease the level to lower than 50, that this is mainly what is partially or well controlled. And no matter of the kind of allergic rhinitis, seasonal, perennial, or the association of both, you are able also to improve the control of these patients. Also, this can be seen from the very beginning, from the 3 days of treatment. You can see 50% or 54% in perennial that you get the well-controlled status for those patients. This is very fast in assessing that. This is a recent picture in a paper very recently published. You can see that association of oral antihistamines and international corticosteroids or international corticosteroids alone are not able in a single patient to control the disease, but when these patients in different moments of the year, that goes from August to December, has the addition of MPS flu, this is able to control the disease. I mean, that is why some patients are using this drug, not always, but on demand when they are in the worst status. This slide also shows that the severity by VAS increases with the severity using the ARIA items, and also the loss of smell increases, smell decreases here in those groups of severity patients, and these are able to be reduced, to be improved, both severity and loss of smell, by the treatment of this drug, that is the association of a corticosteroid and intranasal antihistamine. 2 years ago, in the new algorithm of MAC ARIA, it was reported either in treated patients or in untreated patients, this new way to categorize patients based on control. Putting the more than 5 centimeters uncontrolled, less than 5 controlled or partially controlled. And this algorithm, I recommend that you read it carefully and you use it in your daily clinical practice every day, gives you an approach to have a better control of the patients. Of course, you at the end will finalize with patients that are not well controlled, no matter of which kind of treatment you use, if this formulation of other drugs, and you should consider to reanalyze those patients, to do nasal endoscopy, or to evaluate the possibility of giving allergen immunotherapy. And that is good for both treated and untreated patients. This algorithm that probably it's even easier that Peter Hillings published with a group of experts last year goes also from the beginning without treatment to differentiate between controlled, less than 5, and uncontrolled, and evaluated the number of treatments that we can do or we should do to move the major number of patients with controlled disease that we can achieve. But at the end, we also finalize with a number of patients that we are not able to treat with a VAS higher than 5, where we should evaluate this possibility of nasal surgery, of sinusal surgery, or allergen immunotherapy. And finally, and probably more important, allergic disease is not something that belongs to a single specialty. I mean, most of them, patients with mild disease or intermittent disease, are self-managed by symptoms or with the collaboration of the advice of a pharmacist. That is why it's important to give information by MAC ARIA to the pharmacist how they should behave, what are the order of treatments that they should give or they should advise to their patients. Of course, when patients become more severe, moderate or severe, they usually go to primary care, that probably this group of patients can be treated easily, but some of them, for a final diagnosis, and probably the most severe, should go to the specialist, and some of them probably to the emergency care. And there is a lot of arrows going up and down because it's expected to have a collaboration, a multidisciplinary collaboration in the management of this disease and the comorbidities, mainly asthma and others like chronic rhinosinusitis. Thank you very much. And I show you this figure from Barcelona because maybe we are dealing with the possibility of having the EUFOREA meeting next year in Barcelona, where you will be very welcome if we finally agree on the final conclusions. Thank you very much.